Hello and welcome to another talk in our Initial Assessment of Competencies teaching course. This is going to cover emergence from anaesthesia. So the objectives for this talk are to learn the Guedel stages of anaesthesia and how we can apply those to emergence, learn the important complications that can occur on emergence and in the recovery unit, how we can time patient emergence effectively. We're going to cover some practical considerations when planning to extubate and some techniques that we can employ. And we're going to understand the role of the post-anaesthetic care unit, colloquially called Paku. And as with all of these talks, we're going to establish which other curriculum items are linked to this workplace-based assessment. So the main content that this is aimed at is your IAC A05, which is recovering a patient from anaesthesia. This is a DOPS, typically. And the idea of this talk is to supplement your knowledge. So when you actually perform this DOPS with your mentor, you've got a robust understanding of how to go about doing it. And so you can be a more flexible practitioner in the future. But you can also, scanning through the Royal College curriculum, there's 5 other curriculum items you could link this to. So you'll maximise this workplace-based assessment. And the way that you can do this is with all of the curriculum items is you can choose to attach to any workplace-based assessment an IAC code, which is where the bottom arrow is pointing to. And you can link further curriculum competencies using the top arrow. So you can link as many curriculum items to any workplace assessment as you would like to. So get into the habit of doing that because it's going to reap benefits when you come to your ARCPs and sign-offs. So when we talk about emergence from anaesthesia, we need to understand what we're really trying to achieve there. Now, I think by now we understand what general anaesthesia is, and the emergence from it reflects the patient's clinical state where there is a return of consciousness, neuromuscular condition, and airway reflexes. It's a common time for complications to occur. So if you compare it to intubation, when there's an estimated 4.6% complication rate, actually at emergence there's a 12.6% complication rate. So, almost 3 times the rate of complications. So it really is an important part of anaesthesia to be vigilant during. And there's no single best way to emerge a patient. But the agreed endpoint is that it should be smooth. So firstly, we're going to cover, so taking that first point, consciousness, that has got various metaphysical, philosophical definitions, but for our purposes, this can be considered as the state of intact higher brain function, sufficient to facilitate brainstem function, perception, and the ability to follow instructions. So what we're really looking for here is a patient that can follow instructions, is able to understand where they are, has got intact brainstem function, which means that they can protect their own airway. They have stable cardiovascular and respiratory function, and that it is consistently demonstrated so that we can be comfortable that this patient will be able to maintain that level of awareness. For patients who are under general anaesthetic, we approximate this level of consciousness with a depth of anaesthesia. And what do we mean by depth? So in the 1920s, Guedel demonstrated that there were several stages of anaesthesia or several stages of physiological observations that patients demonstrated when they were having general anaesthetic under ether. And he described them as the process of induction. So people would pass through from an awake phase to a general anaesthetic phase. We're going to slightly turn that on its head, and we're going to consider, well, what happens as patients wake up when they go from the general anaesthetic phase to the awake phase. But Guedel described it during induction. So he took physiological observations as markers of depth of anaesthesia. These included looking at the patient's respiration, which was specifically the diaphragmatic and intercostal muscle function, their pattern of breathing, depth of breathing, and regularity. He looked at ocular movements, whether the eyes were roaming around, whether they're fixed, whether they're able to track, looking at pupillary size, and looking at the presence of reflexes, such as the eyelash reflex, corneal reflex, light reflex, laryngeal reflex, or pharyngeal reflex. Considered patients' muscular tone levels, and also looked at the cardiovascular status of the patient, the blood pressure and the heart rate. And by observing patients going under general anaesthetic using ether and going through these stages of anaesthesia, he was able to break them down into 4 specific stages. So stage 1 is called the Analgesia phase. In this phase, patients are conscious, as we would understand it. They can hear, can see, they can interact, and they might be in a slightly dreamlike state. You might consider this to be a patient who's under very light sedation. If we look at the diagram on this slide, going from left to right, we can see the various characteristics that the patient might demonstrate during this stage of anaesthesia. So their intercostal and diaphragmatic respiratory muscle function is normal. They have a regular breathing pattern, and it is maximal. The eyes are normal, they're able to track, and pupil size is normal. Looking at the reflexes, they have got an intact eyelid, pharyngeal, corneal, and light reflex. Then their muscular tone will be normal. Their blood pressure and heart rate also will be normal. So these are patients who we might come across in that stage of analgesia, on light sedation, having very minor procedures under local anaesthetic, where we may not really even have administered any hypnotic agents at all. Or they might be having Entonox for the purposes of labour. We're talking about that level of consciousness. This is the stage that we want to get a patient to when we're looking to extubate, when we're looking to demonstrate that they have emerged from their anaesthesia. The second stage of anaesthesia is called the Delirium Phase, and it tracks from loss of consciousness at the end of the first stage of analgesia. So these patients are no longer obeying commands, they are no longer interacting, but they still demonstrating automatic breathing patterns. Now it's called the delirium phase because this is typically observed to show very excited and struggling characteristics. You get increased jaw tone. The patient's breathing might become a bit harsher, but still they're doing their own breathing. Their eyes will start to roam around. The pupils will be dilated, slightly crazed look to their face. They will have intact reflexes, such as eyelid, pharyngeal, corneal, and light. Their muscular tone will be increased. Their blood pressure will be elevated. Their heart rate will be elevated. These patients look very agitated. We don't tend to see this during induction because the agents we use, certainly intravenous agents, work in one arm brain circulation, and we get through this stage quickly that we don't see it. However, if you've ever seen the induction of a child under anaesthesia where they've needed to use gas, then you will have witnessed this stage as the patients become a little bit more agitated, move around a bit. They're often at this point sat on their parent or guardian's knees and they're being held. And that's important because we talk to the family before we give a child gas induction to let them know what to expect, because this is a stage that they will witness and they might find quite distressing. But it's important to reassure people that when a child goes through this stage, it is normal, it is predicted. It does not mean that they are in any pain. It does not mean that they are agitated. It means that they are dropping into a deeper plane of unconsciousness. So we don't tend to see it during induction. However, we may well see this stage on emergence. And the reason it's important to know about this stage is because it's associated with laryngospasm and vomiting. And those are definitely things we want to avoid when we are trying to, when we're looking to extubate a patient. You may have heard clinicians talk about patients as they wake up saying, oh, they're still a bit too deep, or they're between planes of anaesthesia. Or you might have had discussions at debrief sessions of patients who've had laryngospasm and said, well, I think they were probably a bit light, or they were between planes of anaesthesia to be extubated. This is the stage that we're talking about. So we do not want to extubate or stimulate the airway in this stage. We want to support the patient and keep them comfortable, unperturbed, while they progress through this stage. And they'll progress through that stage into the third stage of anaesthesia, which is divided into 4 planes. Now, this stage is called surgical anaesthesia, and as the title would suggest, this is the stage at which most of the operations are performed in. It starts off in plane 1, where we've still got intercostal and diaphragmatic muscle function. The eyes tending to stop roaming around as much. I've gone back to a normal pupil size. We've lost our eyelid reflex, and we're starting to lose our protective airway reflexes. Muscular tone, blood pressure, heart rate may all be normal, and we start to see the swallowing reflex disappearing. Then plane 2, your intercostal muscle function will start to decrease slightly. The eyes become fixed. Pupils, again, remain mid-sized. You'll get increased tearing. The laryngeal reflex is lost, and we start to see a decrease in muscular tone, decrease in blood pressure, with a reflex increase in heart rate. Most procedures probably occur in this plane or in the next plane, plane 3, which is where the patient is really apneic. There is very little respiratory muscle function. The eyes are fixed, but the pupils are now dilated. They will typically have lost all of their reflexes at this point, will be hypotonic, and the blood pressure will start to become very low with a reflex tachycardia. Now, between planes 2 and 3 is where most operations are performed. And it's important to know that by the time you got to plane 3, which is what we describe as true surgical anaesthesia, we may need to consider supporting a patient's cardiovascular system. The 4th plane of stage 3 is called diaphragmatic paralysis. And you can see by the presence, or really the absence, of physiological characteristics on this, and it's not really a desirable phase to be doing anything in. You have apnea or diaphragmatic paralysis. You've got a dilated pupils that are fixed. There's no reflexes. Their tone is decreased. Their blood pressure is now dangerously low, and they have got a dangerously elevated heart rate. This is the stage just before stage 4, which I'm not going to talk about, but which you can see grayed out there, called medullary paralysis, which represents a state of multi-organ failure and imminent death. Now, looking at these Guedel stages of anaesthesia, we've spoken about stage 1, 2, and stage 3, with a side mention of stage 4. I've said that stage 1 is where you would consider bringing a patient out of the anaesthesia, where you would think about extubating a patient, where they will probably be able to demonstrate the characteristics I spoke about with consciousness, being able to follow commands, having higher cortical functions, and having intact brainstem activity. However, although we can't emerge a patient from anaesthesia in stage 3, what we might be able to do is perform various advanced extubation techniques, which we'll talk about later. And this is where we talk about deep extubation. So knowing the Guedel stages and the order in which function returns with level of consciousness actually helps to allow us to predict the timing of our anaesthetic. So just as you progress through from stages 1 to 3 during a general anaesthetic, so too when the patient is being woken up, they should go from stage 3 to stage 1. So looking at the patient and seeing which physiological parameters are returning allows you to anticipate which stage you're in, so when you have to be most vigilant, and roughly how long it might take them to wake up. So here I've just demonstrated the parameters that correlate with level of consciousness. So your respiratory drive typically returns with very low levels of consciousness. Now remember in the diagram before, we were seeing that you had diaphragmatic intercostal muscle function even in the sort of latter planes of stage 3. The next reflex that you will see is the corneal reflex. So that indicates sensory function is returning. Typically the patient's eyes are taped, and this is very rarely tested. Then you're going to start to see gagging, salivation, grimacing, and some ocular movement return as their brainstem function returns. Remember, those are the reflexes that we spoke about. Those reflexes start to return in stage 3, going through stage 2. So just because we have got return of brainstem function does not mean the patient is at a level of consciousness that's compatible with protecting their own airway, or that they are in a plane of anaesthesia that's allowing us to extubate. As they become more awake, you'll start to see improving muscle tone. So now their muscle function is returning. And finally, you'll start to see purposeful responses to command, which indicates a conscious awareness that we're looking for. Don't be disheartened if you do not see eye opening, because typically we ask patients to open their eyes, and that's a way of us showing that they can follow commands. But actually eye opening can occur long after they're able to demonstrate response to verbal commands. So a patient not being able to open their eyes does not demonstrate in itself that they are still too deep. Think about other things you can test, squeeze my hand, stick your tongue out, commands like that. So when you are bringing a patient out of anaesthesia, get into the habit of thinking about which of these consciousness correlates they're demonstrating, and so which stage of anaesthesia you might be in. So while we're thinking about those correlates with consciousness, and we know which plane we want to arrive in, so currently we're aiming for stage 1, we know we want the patient to be purposeful and obey commands. So how can we get them there? Well, we do that by removing the effects of our anaesthetic from the patient whilst keeping them calm and compliant. So there's 5 things to think about here. So the first thing is assessing and reversing neuromuscular blockade if you've used a neuromuscular blocking agent. You want to be evaluating analgesia. Should you have started a longer acting analgesic agent? Do they need to have some form of regional anaesthesia or local anaesthetic? Then you're going to think about the timing and how you're going to discontinue your anaesthetic agents. Remember, you don't want to have a patient emerging too quickly, because it's very uncomfortable for a patient to wake up on the operating table, even if surgery is finished, be moved across onto a bed and to be moved out. I think you'd rather have those things done while they are still unconscious. Then you want to evaluate the physiological signs of return of consciousness that we've talked about. And then you're going to think about determining that any artificial airway you've placed can be removed, be it an endotracheal tube, be it a supraglottic airway device, be it nasopharyngeal airway. Preparing for emergence does not begin during the operation or when the operation is finishing. Preparing for this begins at pre-assessment, and we tailor our anaesthetic to navigate these aspects safely. So we should be thinking about the patient we have in front of us and how we are going to recover them from the anaesthetic. What choices we should make based on the procedure they're having and the pharmacokinetics and dynamics that they're likely to demonstrate. Should we be choosing a particular neuromuscular blocking agent? Which analgesic agents are appropriate for this patient that may delay emergence, may put them in a dangerous state of decreased consciousness when they emerge? What's the correct anaesthetic agent of choice for this patient? Should they be on intravenous anaesthesia? Can we keep them on volatile agents? What's the correct type of airway that I need for this patient to secure their airway safely? The first thing to talk about then is the neuromuscular blockade. I'm not going to go into this in too much depth because it's actually covered in much greater detail in another one of our IAC talks on neuromuscular blockade and induction agents. So that's a separate IAC topic. But for any patient that you've given a neuromuscular blocking agent to, it is an AAGBI requirement that you have a nerve stimulator present. It's standard equipment. When we use the nerve stimulator, we're using train of 4 to demonstrate a ratio of greater than 0.9. That is our target. It used to be, in years gone by, a train of 4 ratio of greater than 0.7, but it's been demonstrated that actually if that is that's your return of muscular function, patients still feel quite distressed. They are able to perceive weakness. It's a very uncomfortable phase to be in, and it's not really enough to protect their airways and emerge safely. So we're looking for train of 4 ratio greater than 0.9. You cannot demonstrate that using a simple nerve stimulator. You can demonstrate it if you have something like an accelerometer, something that can actually quantify muscle power. So if you've got just a standard black and red electrode that you're giving 70 milliamps through and looking at twitches, that is not enough to demonstrate a ratio of greater than 0.9. So you have to presume they don't have it. Therefore, in all patients for whom you only have a nerve stimulator, you need to think about the appropriate dose of the appropriate drug to reverse the neuromuscular blockade. And the agents we use are Sugamidex for rocuronium and possibly vecuronium, or neostigmine for the non-depolarizing muscle relaxants. The dose of these is determined by the train of 4 count or the post-tetanic count. If you have 4 twitches, sort of regardless of the amplitude, but you have 4 twitches, then actually you should give the normal dose of neostigmine, which is 0.05 milligrams per kilogram, or you give 2 milligrams per kilogram of Sugamidex. If you have got one post-tetanic count, then you need to give 4 milligrams per kilogram of Sugamidex. And if you've used rocuronium, and if you've used rocuronium and you've only just given the dose, you need to give 16 milligrams per kilogram. Important thing to remember with this is how long it takes the drug to work or to have its maximal onset of action. So you will see when you give neostigmine, we also give it with glycopyrronium, that the glycopyrronium there is there to offset the anticholinergic effects of neostigmine. You will see within seconds a tachycardia from the glycopyrrolate. That does not mean that the neostigmine is at its optimal levels, has reached its target receptors to work. It takes an average of 8 minutes for neostigmine to have its maximum effect, and it takes about 3 minutes for Sugamidex. So when you time your reversal, just remember that But actually the time to give reversal is not when you've got the patient off the operating table onto a bed, sat them up, and you're waiting for them to obey commands, and then you give it. You should be giving them the reversal, if it's appropriate to do so on the train of 4 count, really as soon as surgery has finished, or you feel you've got at least 8 minutes before you're going to try and take any airway device out of them. So the next thing to think about is what we're going to do with any inhalational anaesthetic agents we might have used. So the clearance and termination of effects depends on the concentration gradient from the brain, which is the target organ, to the blood, and then to the alveoli. The alveoli is the interface by which we absorb and we excrete our inhalational agents. But the concentration gradients between those phases from the brain to the blood to the alveoli will reflect as the speed at which the agents come out. So these gradients can be affected by the partition coefficient of the agent. So a low blood gas, a low brain blood, and a lower tissue blood partition coefficient. It's also determined by the minute ventilation and the fresh gas flow. So what we sometimes do for patients is you might see patients moved across, they have their gas flows turned up to 15 litres in a way to try and wash out the agent. What you might see is that some people look to lower the respiratory rate of a patient, so that stimulates the respiratory centre to start breathing. So they start breathing spontaneously on their own. So it's a common thing to do to get people breathing for their own, but what you should know is that in doing that, you've decreased their minute ventilation. Therefore, you've slowed the clearance of any anaesthetic agent. So while they might be faster to breathe for themselves, they are probably going to be slower to wake up. Then there's your cardiac output. So increased cardiac output leads to an increased washout of your anaesthetic agent. So any increased cardiac output state will lead to a faster clearance. The next is the duration of your anaesthesia. So although the actual clearance doesn't change too much with prolonged anaesthesia, if there is a high tissue to blood coefficient, then you will get a corresponding prolonged emergence. And typically, desflurane is cleared faster than sevoflurane, which is cleared faster than isoflurane. And then the next thing to think about is whether you've used what you call a second gas. So if nitrous has been used, nitrous, when used, can increase the speed of induction and can increase the rate of emergence. So you can see that knowing the pharmacology of the agents allows us to time their clearance, allows us to think about how we're going to get a patient out of their anaesthesia. The actual values for these coefficients is beyond the scope of initial assessment of competencies. It's something that gets covered in your primary examinations. It's enough, I think, to be aware of these concepts and how they're going to affect when you're going to turn your inhalational agents off. Well, what if you haven't used an inhalational agent? What if you've used an intravenous anaesthetic agent? So here your recovery depends on the rate of clearance from the brain compartment, either by redistribution or elimination. So before I go on further, I'm just going to explain what those two things mean. So redistribution is where you've given an intravenous dose of an intravenous hypnotic. So let's say propofol. The propofol will go into the vein. It will go in one arm brain circulation to the brain, where it'll be taken up and it will exert its effect. Then the propofol will start to distribute itself to other tissue organs based on the lipid solubility and the vascularity of those organs. So the patient will fall unconscious within one arm brain circulation, and then the concentration of the propofol in the blood will rapidly start to decrease as it gets redistributed to other tissues. So the rate of recovery from a bolus is determined by redistribution. If you have a patient who's on an infusion, so you've already induced them, they're now being maintained on propofol, then their recovery is dependent on the elimination of that drug. So the elimination is affected by the duration of anaesthesia. So as I said, if it's just been a bolus, then it's the redistribution. If it's been a prolonged infusion, then we're talking about the context-sensitive half-life, which for all agents, apart from remifentanil, can be interpreted to mean that the longer you have been running an infusion, the longer it will take for that agent to be eliminated. Then there's the lipid solubility of the medication. So the more lipid soluble agents typically tend to sequester in the body for longer and then take a while to seep out of those tissues to be eliminated. The metabolism of the agents, so your liver and your kidney function, and the patient's age, which also has got an effect on your liver and your renal function. Now, it's only propofol that's really routinely used for intravenous infusions in theatres. And for TIVA, or total intravenous anaesthesia, we may add remifentanil. So it's enough, I suppose, for the IAC to think about how propofol and remifentanil will behave. Remember, propofol, the longer the infusion goes on for, the longer it will take to be cleared, therefore the longer it will take a patient to emerge. With remifentanil, it is metabolized by plasma esterases, so it doesn't depend on particular organ function, so it's cleared very quickly. But if it's a bolus, then both propofol and remifentanil are cleared, redistributed very fast. However, we should know that there are patients who fall under, I suppose, the umbrella of anaesthesia who might find themselves in intensive care. And these patients might be on midazolam, ketamine, morphine, fentanyl. So you should have a look, even at this stage, at the effects of midazolam and ketamine, morphine, and fentanyl on these patients and how it will affect their emergence. So we've covered the pharmacological aspects to facilitate emergence. So now we think the patient is ready to have any artificial airway that we've placed removed. We should think of extubation as an elective procedure. We've already undertaken a risk stratification that started when we did our preoperative assessment. And we should be mindful of the fact that although we're removing the tube, it's a very stimulating time. And the stimulus that you're going to observe is characterized by typically transient hypertension, tachycardia. There may be coughing, agitation, breath holding, and raised intracranial pressure. Now, just thinking about those physiological responses, it sort of follows on from that which patient groups are most at risk of severe complications. We're thinking about patients with cardiovascular disease, cerebrovascular disease, raised intracranial pressure or intraocular pressure, and those who've had neck surgery. So it makes sense to think about how we can minimize these effects. And there are a few ways in which you could do this. Some practitioners may give lidocaine, which can either be administered topically or intravenously. Opioids themselves that may have been given intraoperatively have got a strong antitussive effect, but we should remember that they've also got they can blunt the respiratory drive. Dexmedetomidine is a drug that, when given either as a bolus or an infusion, attenuates the hemodynamic response to extubation. And if you had patients who were on a remifentanil infusion, you can continue that on a very low dose allowing the patient to follow commands and allowing them to breathe spontaneously and then to extubate. Some practitioners, though, might employ non-pharmacological techniques in order to facilitate a smooth emergence. And under this, we think about two particular techniques. Would be deep extubation, which we mentioned before, and the Bailey maneuver. So before we go on to deep extubation and the Bailey maneuver, we're just going to recap on what an awake extubation, which is the bread and butter, it is the most commonly performed technique, is. Now, the awake extubation can be modified to be also a no-touch technique, which you may hear clinicians talk about. We'll talk about both these just now. So we oxygenate the patient, being mindful that we want to avoid absorption atelectasis. We position the patient optimally, which is to aid spontaneous ventilation and our access to mask ventilation, so typically a ramped position. You want to optimize your environment. You want the necessary people to be present, and you want it to be a quiet environment. You want to make sure that you have adequately reversed the patient, as we've spoken about. You've anticipated their analgesic requirements, and you have the patient spontaneously breathing with a regular pattern. You want to ensure that their oxygen saturations are sustainable and that they have got a purposeful response to any instruction you give. Remember, eye opening may not be present. It doesn't mean that they can't follow commands. You want to clear any secretions that they've got in the mouth and make sure you have a bite block inserted. When it comes to the moment of wanting to take the tube out, you are going to want to do this on inspiration while there is some PEEP. So what this typically means is that you'll do a recruitment breath, deflate the cuff as they're inspiring. And then once you've done that, you put the patient on a face mask, make sure that they're breathing, they haven't gone into any laryngospasm, and then you can move them onto a Hudson mask, for example, and you can transfer them to the Paku unit. Important things to remember here are that if it's been nasal intubation, then you may well have some bleeding. It's very friable vascular tissue in the nose, so you may get pooling of blood in the back of the throat, and through the procedure this can form a clot, and this is sometimes called a coroner's clot, because on extubation, when you do not have a secured airway, this clot can dislodge and then it can obstruct their airway. So it's important that you suction. Now, the way that this awake extubation can be modified is with a no-touch technique. What this means is that the airway is suctioned whilst the patient is deep, and that the patient is allowed to wake without any encouragement interference. You're not shaking the shoulders, you're not screaming into their ears, you're just letting them go through their stages of anaesthesia in their own time. The next technique to talk about is deep extubation. So deep extubation is where we are removing the tube while they are in stage 3 of anaesthesia. It reduces emergence phenomena like coughing, straining, spasm, and the hemodynamic stress, and it is considered an advanced technique by the Difficult Airway Society guidelines. So if you remember the diagram when we went through these stages of anaesthesia, these patients do not have protective airway reflexes. Therefore, there's a risk of aspiration and obstruction. So it is contraindicated in patients who are at a high risk of aspiration. It is not a suitable technique for patients where face mask ventilation or reintubation would be difficult, or if you've performed an RSI, or if the patient is deemed to have a full stomach, if the patient is obese, is pregnant, or has ascites, or if the patient is diabetic. Deep extubation is only a technique to mitigate the stress response to extubation, where you think it would be appropriate for that particular patient and that particular operation. The reason I say that is because the incidence of respiratory complications as a whole are dramatically decreased when extubation is performed with the eyes open and the patient spontaneously breathing. Then the third technique to think about is the Bailey maneuver, which is where we substitute an endotracheal tube for a supraglottic airway device while the patient is deep. This allows us to protect the glottic area from noxious stimuli that may trickle down from the back of the throat. It's easier for a patient to spontaneously ventilate on a supraglottic airway device because of the caliber of the tube, and patients typically find it more comfortable when the supraglottic airway device is removed. Which brings us on to emergence with a supraglottic airway. So obviously not all general anaesthetics are performed with an endotracheal tube. In the UK, 56% of general anaesthetics are performed with a supraglottic airway device as the primary airway management device. And as we've spoken about with the Bailey maneuver, the supraglottic airway might be used to facilitate deep extubation. I mentioned that it's typically better tolerated in lighter planes of anaesthesia than an endotracheal tube. Having an endotracheal tube is very stimulating. If you have seen patients who are on intensive care, we typically need to have them on remifentanil, some sort of analgesia, for tube tolerance. A supraglottic airway device is not definitive, but they are engineered and shaped to prevent dripping into the glottic opening. So actually, when we remove a supraglottic airway device, we're also removing a lot of the secretions that have pooled onto it out with it. And what you may well find is that while extubation is very much the responsibility of the anaesthetist, you may have a post-anaesthetic care unit that is prepared to accept patients who are self-ventilating on a supraglottic airway device, and that the staff there would be comfortable to remove the supraglottic device. So it can be a way to facilitate turnover of patients from a list in a safe way. But that depends very much on the skill set of the staff in PACU and whether you are happy to divest that responsibility to somebody. Now, there are instances where actually what we might want to interrupt emergence. So we've started the process, the patient is waking up, but something unanticipated has happened. Either the surgeons have decided they need to intervene, or the patient is so agitated during your emergence that you cannot do it safely. So it's not just a one-way process. Remember, you're going through stages of anaesthesia. So just as you can go lighter, you can also go deeper. If you're looking to interrupt emergence, you're probably looking to do it quickly. So usually you're going to accomplish interrupting emergence with a short-term intravenous anaesthetic agent like propofol. If you're just trying to arrest emergence with a view to getting back on control of it and trying to guide them through the process smoothly, then just a one-off bolus of an IV agent might be enough. But actually, if something more involved is required, if the surgeons are going to need to intervene for whatever reason, then you'd give them a bolus of an IV anaesthetic agent and then put them back onto whatever sedative choice they were previously on for an operation. If it's really a short interruption, as I said, propofol's fine, but you might also consider adding some nitrous in as well. Remember, nitrous, when you add it, has got potent analgesic effects as well. So when we're quite junior, anaesthetists might be drawing up our emergency drugs, and some of that may well be propofol. And we talk about that being used to prevent laryngospasm, but also it's also very important to think about it just in the wider scheme of managing emergence, because you may well use it for interrupting, for delaying, for getting back in control of emergence. So if you take a patient intubated anywhere have some propofol with you to facilitate any changes that you might need to make. So we've taken out the airway device. We feel the patient is awake, alert. They've emerged from their anaesthetic. Hopefully that means job done. However, there are some very important problems that may result after emergence from a general anaesthetic. This is very much why we have a post-anaesthetic care unit and why we have very strict standards for monitoring patients until they are fully recovered from the effects of an anaesthetic. So the potential problems we might experience are respiratory failure. So patients might hyperventilate, could be as a result of the drugs we've given them. Could have airway obstruction. They could be bucking. It could be laryngospasm, bronchospasms. They could have central apnea, by which I mean they've either had an agent that has rendered them apneic, like a strong opiate. They could have had a cerebrovascular incident. There may be ongoing paralysis, or they may have aspirated. So those are all important things to think about if you have a patient with respiratory failure. Secondly, there might be delayed emergence. So things seem to be progressing very, very slowly through those stages of anaesthesia. So we should think about whether there's any opiates that might be prolonging effects, whether the patient is actually reversed. Is there some residual neuromuscular blocking agent effect still on board? So the patient is awake but is unable to demonstrate that to us. Patients who have reduced metabolism, kidney, liver disease, may have delayed emergence. If you turn down their tidal volume or their minute ventilation in order to build up the CO2 to get them to breathe for themselves, their CO2 levels might be high enough that they've got narcosis. So they are breathing for themselves, but they're not actually able to demonstrate consciousness. There may be some sort of metabolic problem, such as hypoglycemia, or they may have had a cerebral event. Then we should think about delirium, potential problem after general anaesthetic. And this is especially common in children and also in the elderly. So the differentials for delirium are multiple. Certainly there's some evidence that sevoflurane itself increases the risk of delirium in children. So isoflurane might be a better choice. But pain needs to be considered. Use of anticholinergics, especially in the elderly, needs to be considered. Ketamine, if that's been used, then we should anticipate, in general anaesthetic doses, then we should anticipate some delirium. And so benzodiazepines can be used to try and mitigate that. If the patient's hypoxic or hypocarbic, they can be delirious. Hypoglycemia can cause hypoglycemic effects if they've got raised intracranial pressure, or a side effect of general anaesthetic that we don't often mention to patients but is well documented. They may be in retention. So pain itself after emergence is a problem. They may not be delirious with it, but it's an uncomfortable sensation to have. So it's important to try and optimize their pain post-op. When managing their pain as they've recovered from anaesthesia, you want to make sure that you're using an appropriate dose so you don't risk a patient losing their airway or ventilatory drive. You should also think about whether actually they are adequately, they have got adequate analgesia for the procedure they've had. Has something happened? Is there more blood coming out of any drains that they might have? Are they hemodynamically unstable? Is there a reason to think that this patient actually might need to go back to theatre? Which leads me on to hemodynamic instability. So if you've taken away any sympathetic tone as a result of the depth of the anaesthesia that you've given them, or the use of some of the agents, if they've had a spinal, they can be hypotensive as they lose their sympathetic tone. Pain can cause people to be tachycardic, hypertensive if they're agitated for whatever reason. Patients who are coughing, especially patients with asthma or smokers have got very reactive airways and they can cough a lot, and that can drive up their blood pressure, their heart rate, and their intracranial pressure. Hypothermia and shivering is common, and that can sometimes be put down to side effects of, say, a spinal. It's very common that patients might be shivering or itchy afterwards. But also, how have we been maintaining normothermia for patients? Have we been using a bear hugger? What's their temperature in recovery? Important to warm them up. And post-op nausea and vomiting, very common. And that'll be covered in a separate talk as part of the IAC series. And you need to think about the patient's risk factors for that. That should have been considered in your preoperative assessment, and you should have chosen agents that would mitigate the risk that you perceive during the operation. But if they've got a full stomach, then they're more likely to be feel nauseous. Certain operations such as inner ear or gynae operations are more associated with post-op nausea and vomiting. If they've got an NG tube in, then consider aspirating it just to make sure that they haven't got a full stomach and that's causing them to feel nauseous. And it could be a side effect of medications that we've given them. We give strong opiates. That's a well-recognised side effect. We've already touched on PACU a little bit, but I just want to go into slightly more detail. So the post-anaesthetic care unit provides an area for patients to continue their recovery. It's not practical to have a patient become go from a general anaesthetic to fully aware in an operating theatre and in any way hope to maintain throughput of patients through elective surgeries. There needs to be a recovery area. And any patient who's had a general anaesthetic or neuroaxial anaesthesia should be recovered in a post-anaesthetic care unit. So that is in the AAGBI guidelines. Obviously, local policies will trump, but the AAGBI guidelines are national. And you should expect that your patient will have one-to-one care until they have full control of their airway, they have stable respiratory and hemodynamic systems, and they're awake and can communicate. That's full one-to-one care. If you cannot expect that, then you need to think whether that's the appropriate place for them to be to, or whether you need to stay with them, because ultimately you are responsible for their recovery. Extubation is certainly the responsibility of the anaesthetist, and as I've said, most PACUs can manage supraglottic airway devices, but if they can't maintain one-to-one care until those three targets have been met, then you need to stay with the patient. Now, there was an anaesthetic incident monitoring study of over 8,000 patients showing that most extubations in the UK occur in theatre. And the study found that 5% of these patients had some form of incident in the post-anaesthetic care unit. 43% of those incidences were related to the airway. And they found that 20% of patients would have saturations of less than 92% by the time they arrived in the PACU. So it is common for patients to have problems in PACU. It is very common for those problems to be related to their airway. And in a significant number of people, we are delivering hypoxic patients to the post-anaesthetic care unit. So that's why it's so important that you are happy that that patient is well looked after and has got one-to-one care. And I would encourage everybody to transfer a patient from theatre to the PACU on high inspired oxygen. If the patient has got a supraglottic airway device, or if they've got an endotracheal tube, you should transfer them on some kind of water circuit. So we know what the patients are expected to receive when they come to the PACU. Or what will it take for them to be discharged? Well, discharge criteria, again, are a responsibility of us, the anaesthetists. But we can delegate that to staff as long as we've demonstrated clear parameters. The AGBI has got clear parameters, but also your own institution will have its set of criteria for discharge. Often there's just a very standard bundle or standard set of targets that patients need to meet, and that's been agreed between the anaesthetic, surgical and recovery staff. But the minimum criteria for our purposes as anaesthetists from the AGBI are that the patient is fully conscious, maintaining a clear airway, that their work of breathing and their saturations are satisfactory, that they are hemodynamically stable with no bleeding, and they have got a target blood pressure that they're achieving consistently. Any pain, nausea or vomiting is adequately controlled, and where needed, drug interventions are prescribed and can be continued in that form on the wards or on discharge, that they have reached a target temperature that is appropriate. Any oxygen therapy that require is prescribed with target saturations, that they have patent and flushed intravenous cannulae. You'll often find that you've got three-way taps or caps that have got evidence of propofol in them. It's not going to be enough to cause any harm to a patient if that was to be flushed through, potentially. But it sort of represents a wider problem with a patient who's not perhaps been adequately prepared to come to the recovery area, not been thought about. And then the patient needs to have complete medical records and their notes present with them. So I suppose what we've really done there is we've covered the process of a patient going from the third stage of anaesthesia all the way through to PACU and discharge from that unit. And just to recap, so we've spoken about the Guedel stages of anaesthesia, how they came about and how we can apply them to emergence, the important complications that can occur on emergence and in the recovery unit, how we can time the emergence of a patient from anaesthesia, practical considerations when planning to extubate, and the role of our PACU team. I hope it's been a useful talk. We've got a SurveyMonkey survey just below, or just in the links below this video. Really very keen to get this project up and running and improve it. So anything that you can suggest, anything you think works well or doesn't, please do leave some feedback. It's very much appreciated. Thank you very much.